So good evening, everyone, and welcome to the Radiology ST1 interviews webinar by UKRST. So I'm Avira. I'm a consultant radiologist at Oxford University Hospitals. I finished my training last year and started the consultant job here. I've got with me Umar Sabir. He is ST1 in Northwest Deanery in Manchester. And I've got Shoaib, who is also our chief organizer at UKRST. He's ST4 IR and also in Northwest. So just some general housekeeping rules before I start off. So just keep your audios and your videos off throughout the presentation while the webinar. However, you can put your questions in the chat box and I can take them as we go through if they are related to where I am at the point of presentation, and we can go through the questions at the end of the webinar. I would also request if you keep the questions directed towards the interview preparation rather than asking questions about portfolio and uploading evidence on the portfolio, as there are lots of questions on the WhatsApp group. Okay, so wait. So what I'm going to go through today. So first of all, well done, congratulations, you're halfway there. And passing MSRA is really, I think, it's one of the most crucial steps in radiology these days, because once you're done with MSRA, you have at least 50% chance of getting the interview slot. It's like a 1 in 2 ratio, and it has always been like that. So interview bookings are not open yet. I'm not sure exactly what date they are opening. They said it's going to open on the 26th, but if they open beforehand, they will let you know and they notify you by email. And again, you're through your Oriel. I don't know I'm getting a beep when I press. Sorry about that. So one advice I would give you, the interview dates are going to be from 10th to 14th of March. I would advise you to check your rotas beforehand and just keep yourself in mind what date you want to book the interview. For example, if you're doing a night shifts on the weekend, you don't want to do the interview on a Monday. It's probably better if you do it on a Tuesday or anything and any day after that. So keep in mind what dates and the timings this suit you, and you should not be working on the day. I think you should be in a relaxed environment. You shouldn't be taking interviews, which is like a professional interview. This is like a game changer. You have done half of the work. You've bypassed the MSRA. So don't take a risk of taking the interview in a hospital setup with the internet. You're not sure if it's going to work. We're going to use your mobile phone or your laptop. The connection is not working. So the basic things like that. So the radiology interview process over the years, it has changed quite dramatically. So I can tell you from 2019, I don't know if you guys are leaving a beep or something. Okay. So I went for my interview in 2019. So that was before COVID. And at that time, it used to be face-to-face. We used to have 2 stations. One was commitment to specialty and the other one was portfolio. And the ranking was 33% of everything, like for your MSRA score, your portfolio score, and your interview. So it's basically MSRA also made up a lot of your chunk of your the weightage in your ranking. So even if you did really good in an interview, it wasn't really making much of a difference. I mean, it did. It would cover up your MSRA, but you had to do equally good in all the 3 domains to get a good rank. Guys, are you getting like a beep? I don't know if I'm when I change.
I think
Okay.
it's from the waiting room pop-ups. You're not supposed to hear it when you speak. Trying to find a way to turn it off. The speaker is not supposed to hear it though. Let me just.
So after 2020 to 2019, COVID came, the interviews, they went back to online, which I think personally I wouldn't prefer, but now that's the way it is. I found really the face-to-face interviews were much better. Maybe I did it that way. However, fast forward a couple of years ago, like a few years ago, The major change came in 2023, where the portfolio criteria drastically changed. So previously, before that, it used to be only 5 domains. It was basically a tick-off exercise. So basically, they changed all of the portfolio criteria, and there was like a long list of 7 components, and you had to score really good in every domain, and the total marks went up to 45. The interview station also changed over these years, and there was one interview station of 15 minutes, and this changed from like 2021 up till last year or the year before that. What happened last year? So there was a major change in interview format and the style of questions asked, because I think before that they realized it was just the radiology, the interview format was just getting repetitive. It was the same style of questions they were asking, and they were basically not able to differentiate the candidates, like who's better than the other. So again, it was online. There were 2 10-minute stations. We'll go through this in detail. And the ranking was like 20% of your MSRA, 30% of the portfolio, and 50% was interview. So do we know the interview format for this year? No, not really. So what do? We always look at the previous year. So last year also, when the interview format changed at the last minute, so I did a webinar which was which covered the prioritization scenarios. You can go on our website and find it on our YouTube channel. So how do we prepare for interview this year? I think it's gonna be almost similar, or probably exactly similar to what it was last year, but do expect that there can be a bit of changes, because that's how RCR is. So the major change this year is one thing, that the MSRA is only used for shortlisting, so it does not account any weightage in your rank. So 40% of your ranking will be based on portfolio and 60% will be based on interview. So you can see it carries a lot more weightage than ever. Also, if you listen to our previous webinars, Umar and Alexander, one of the two ST1 trainees at the moment, they basically showed some statistics from last year, in which they showed that even if you had a portfolio score of 30 out of 45, but the people who did really, really well in interviews, scoring 58 or 59 out of 60, they ranked in like the top 10 or the top 30 in ranking in the country. So you can imagine this year that interview weightage has gone from 50 to 60. So it carries a lot more weightage. So you have to prepare really, really well for the interview. So what's the format? So we'll just keep in mind the format from last year. If new changes which come in place, then we can always talk about it. So it's going to be online, that we know. Before you go for the interviews, there would be a station for your ID checking. So someone will confirm your face ID. There would be 2 stations. So station 1, prioritization, and station B, which was last year, it was mentioned as specialty skills. Who will be interviewing you? These are consultant radiologists. So just keep in mind that although you are an F2, or if you are coming from like, if you're an ST3 or 4, changing your specialties, just remember that the people who are interviewing you are looking at you in a way like you're going to be a future colleague with working with them for the next 5 years. So these are the people who know inside out of radiology. So this is the interview format, which was last year, as I explained. So you enter the room. So the panelists, they may not may not introduce themselves. Sometimes they do. You can have any station in any priority. For example, someone can go for the station B first. Someone can go for the prioritization station first. So what happens in the prioritization station? You will be given a set of scenario, like, for example, we'll go through it in detail. You will have 1 minute of reading for that, the prioritization set. Then you will have 6 minutes of questioning and 3 minutes of further questioning. So what is this 3 minutes of further questioning? Again, it can be anything. They can ask you something about this scenario. They can talk about something else. We will talk about it later. Then you will have a 5-minute break, and then you will have a station B. Again, they will have 3 questions and 10 minutes again for this station. So what would be 3 questions? We can discuss this later. Okay, So I will talk about prioritization, and I will ask Umar to go through the person specifications or the specialty skills, which is more related to that. So as I said, we did a webinar last year, so you can go through that, in which I have gone through lots of protocols for like vetting of CT scans, MRIs, and it just basically just how this, what types of prioritization scenarios you can get. And we'll also go through some examples today. So the prioritization tasks, they can be variable. What are the possible scenarios? So a task can be given in which you are the treating clinician. For example, you are an emergency doctor, or you are an SHO, or medical or surgical registrar, and you must act on the information provided. A second scenario that they can give you is you will be given a task in which you are a radiology registrar and who has to prioritize the work. So this can include vetting of the CT scans, vetting of MRI scans, and plus minus dealing with interventional emergency procedures along with vetting of those scans. So this is the first set, which of the first example that I said, that they can give you a set in which you have to act as an emergency physician. And this is the example which I have taken from Oriel. So I thought that you have an example. Let's go through this. So as you can say, they said you have 1 minute for reading, and it's quite a lot of text, right? So you have to be quite alert, but again, you have to be patient, and also just don't lose your, just don't get upset that you have a lot to read. Obviously, you don't rush through it, but make sure that you have read all the buzzwords. So what does it say? So the clinical history is 33-year-old male, road traffic accident. If you don't know the mnemonics, just make sure you get through, or like maybe read a little bit on the clinical history. So the GCS is 13, pulse is 114, blood pressure 80/40, SATs 90% on 5 liters of oxygen. Okay, so first of all, what do you have to say? You have to see the age of the patient. That is important. Not in this scenario. I will give you an example as to why this is important. For example, if it's a pediatric patient, you have to make sure what would be your response, right? So the GCS, obviously, this is really important. Then what are these signs? Obviously, this patient is tachycardic, this patient is hypotensive, and this patient is also losing his saturations. So he must have had a CT trauma series. So a CT head, which shows a left extradural hematoma measuring approximately 5 centimeter. It overlies the frontal temporal parietal lobes. There is no midline shift, tonsils above the level of foramen magnum, skull vault and base are unremarkable. Okay, fine, you read about the chest. There's no mediastinal hematoma. The vessels opacify normally. Multiple left-sided rib fractures, left-sided tension pneumothorax, maximum depth of 8 centimeter, 3 centimeter mediastinal shift to the right. Okay, fine. You find there are some findings in the head, there are some findings in the chest, and there are further findings in the abdomen. There's extravasation of contrast arising from the left renal parenchyma, perinephric hematoma, retroperitoneal hematoma, and also layering of blood within the pelvis. And they said the rest of bowel is unremarkable and there is no bony injury. So they will ask you, how would you act on these? So what is your basic approach? So back to the basics again, that is really important. What's the basic principle? Obviously, we all know it is ABCDE approach, fine. So this is like generally you should apply this in every scenario. If you are, whatever scenario they give you, you always have to approach ABCD approach. So A is for airway. Obviously, if it's obstructed, that's an emergency. So you have to protect the airway first. Breathing, life-threatening conditions, acute severe asthma, tension pneumothorax, a hemothorax, or pulmonary edema. Does a patient have any of these? Yes, they told us he has got a tension pneumothorax. C, circulation, color of the skin, capillary refill time, heart rate, blood pressure. Does our patient have any of these? Yes, he has got high heart rate, he has got low blood pressure. So this needs to be dealt with first, followed by this. Disability, common causes of unconsciousness, you have to rule out if there's any hypoxia, if there's any cerebral hypoperfusion, have there been any drugs or sedatives he has taken. and then exposure of the extremity. So this is the basic approach. Whatever scenario you are given, just don't worry, and then just apply the same principle. Just say, I will follow A, B, C, D, E approach. So in this scenario, how will you deal with it? So if I was given this scenario, I have to make sure the patient's airway is patent. Then I have to deal with this tension pneumothorax. So this is a chest X-ray I've given for an example that I show you. So you can see the right side, you can see the normal lung markings. So, and you can see, you can count the ribs, you can see a good right hemi diaphragm. However, if you see on the left side, this seems all black. You can't see any lung markings here, right? So, and then you see this blob of area or the opacity, which is basically the whole of the lung is collapsed, right? So then again, what do we see? This is obviously not for this patient, but then you can see at least 2/3 of the heart shadow should be on the left side of the patient. However, in this case, you see that the heart is more shifted towards the right. All the trachea is probably just over here. It looks like it is also deviated towards the right side. So that means this is like a big tension pneumothorax. So this has to be dealt with. And then you would not just say it's a tension pneumothorax, so it has to be dealt with first. You have to tell that how will you deal with it, because they told you that you are the emergency physician dealing with this patient. You would say this is a medical emergency. This patient would need a needle thoracostomy. And I would put like a needle in the second intercostal space in the mid-clavicular line. So these are like the basic things they are expecting from a person who is working in A&E. So yeah, so as I said, first of all, the airway is dealt with, the breathing is fine, then C, circulation. Then they told you that he's got a big hematoma, and then he's also, there's contrast extravasation, which means that there might be a rupture of the vessel. So what will you do? There's an acute blood loss, there is contrast extravasation. They have put in that scenario because also they are testing your radiology skills now. So what would you do? You would not only you would say that I would contact the radiology department specifically for IR, that interventional radiology, and what they do these days is they can embolize the vessel, like for the acute bleeding, wherever it is, or you can say it would be plus minus surgery. For example, if they say there is no IR in the hospital available, then you would say I would contact the general surgery department. So in this case, you can see there is a big perinephric hematoma. There's a lot of this perinephric stranding. Obviously, this is not exactly this case, but then you can see the normal right-sided kidney, but the left kidney is quite distorted. This I've just put in for an example. For example, the renal trauma, it's ideally scanned in a triple phase, which is like you do ideally a non-contrast phase to look for an acute blood. Then you do an arterial phase, and then you do a delayed nephrographic phase. So it tells you like where exactly the bleeding is coming from, if there's a ureteric injury or not. So you don't have to, this doesn't apply for this scenario. I've just put in for renal trauma what we do. But however, in an acute setting, the CT protocols that we use is the Bastion protocol. Again, if you go back to the webinar, I have covered that in detail in the webinar, different types and phases of the CT scans. Okay, so some people would probably think that if there is an intracranial bleed, why isn't it coming at the door? Why is that not a priority? Yes, it is. However, I would say after breathing, you can say, like, for example, I think the intracranial bleed and the abdominal bleeding, both of them are equally important and they should be dealt with. I would contact the neurosurgical team also. However, I think because the patient is actively losing a lot of blood and he's hypotensive and he's tachycardic, he's going in shock. So probably the source of bleeding from the abdomen should be dealt with first. So if you go back to the scenario again, they told you it is 5 centimeter in depth. They told you specifically there was no midline shift, there was no mass effect, and the tonsils are above the level of foramen magnum. So these are the things you're looking for whenever there's an intracranial bleed, and if there's a mass effect. So over here, you can see this is a lens-shaped extradural hematoma. Acute blood is always it's a bright or it's a dense on CT. As you can see, it is white, it is lens shaped. However, you can see that there is not much in this scenario. Maybe a little bit of parafalcine. Fox is slightly deviated to the right. However, there is no big mass effect. And then you have to go in and see there's any uncal herniation, if there's any tonsillar herniation, if there's any subfalcine herniation. So extradural hematomas are a neurosurgical emergency because these are bleeds from the middle meningeal arteries and they tend to expand really quickly. So that's why you have to involve the neurosurgeon so that they are aware. However, at the moment, this patient is stable because there's no mass effect or midline shift, but then you would say that they can expand really quickly. And I would also inform the neurosurgical team and they can then decide if they want to operate or once the patient is stable or not. Fine. So any questions regarding the first set in which you are, do we have any questions, Talia?
There's nothing in the chat box yet. If anyone has questions, please pop it in the chat box.
Okay.
Someone just put query chest drain.
Yeah, you can for the needle thoracostomy or chest drain, both are fine. Yeah. But that's the first is like if you just have to manage then acutely, you just put the needle in and relieve the pressure. Okay. So that can be one kind of set. Another kind of prioritization scenario you can get is, which I think probably but people would find it hard, I don't know. If the task is given as a radiology registrar, you have to keep in mind a few things. For example, they can give you a scenario in which there are 5 CT requests. They can give you a scenario in which there are 5 MRI requests, or could be a combination of both. Or sometimes they can give you a scenario in which they have requested for a CT, but then you have to decide if the patient needs the CT scan or if they need another set of examination. For example, is the CT going to be helpful or not? For example, you do an MRI or you do an ultrasound, which is the first line. I would probably answer the question. So what is the most urgent request? Does it look like it's a medical emergency? For example, a high-speed trauma that would be top on your list. Reading the clinical history, again, as I said, is really, really important. If you see anything with like low GCS, patient's vitals are unstable, again, is the correct modality requested? How would you protocol or with the scan? They might not ask you in detail, but they may ask you. So you need to know like what are the different phases of contrast, non-contrast scan with the contrast or the triple phase. And keep in mind ionizing radiation and IRMA. And if it is a CT or an MRI scan, you have to keep in mind, is it out of hours, right? So in a lot of DGHs or like district hospitals, you don't have MRI availability after 5 o'clock or after 7 o'clock or overnight. So they tend to go to another hospital, which is within the within the region, or they have to wait till tomorrow morning. So you have to keep in mind all these things, right? How will you get to know this? I would say there is no better way of learning these unless you visit the radiology departments and you know how these things work. That's why the taster weeks and everything is really important. And if you have not been to the radiology department in a while, for a year, or maybe last time you went to radiology department for your taster week was a year ago, I would really stress that you should go and sit with the radiology registrars or consultants over the weekend and just see how the things are run in radiology department. Okay. So we'll do another set of prioritization. So you're a radiology registrar on call on Saturday. So again, and your consultant is busy doing interventional procedure, how would you prioritize the following? So first of all, they have given you that you are a radiology registrar, but it's a weekend shift, right? So it's not like the department is fully staffed. And they already told you that the consultant is busy and you have to prioritize these, right? For example, number 1, oncology registrar asking for up-to-date CT scan for a young patient with Hodgkin's lymphoma on treatment. Second, 55-year-old male with tearing chest pain, hypotensive, tachycardic. A colleague asking for CT scan for his mother, who is in ED with the symptoms of gastroenteritis. 80-year-old female with head injury following a fall on apixaban, GCS is fine, no neurological deficit, headache or vomiting. Medical consultant asking for a VQ scan in a pregnant lady with suspected PE, they're clinically stable. Okay, so we'll go through it one by one. So I'm sure most of you must have picked up which is the most urgent scan. So from all these, I think the one with the second one in which they're saying a tearing chest pain, hypotensive, tachycardic. So these are alarming symptoms. As I said, always go through the clinical history, what they have given you. So if I get this on my CT vetting list, I would be really concerned about this patient. I would literally call them and I would ask, I will tell my radiographers, we have to scan this patient, cancel everything else, just bring the patient to the department. Why? Because I'm suspecting acute aortic syndrome. Right, so he's got chest pain, he's got high blood pressure is low, he's tachycardic, right? So then they can ask you, so what are you suspecting? What will you do? So that's your response. We'll go through it later. So, okay, fine. That's the first one. A second one on, okay, we start from the beginning. Oncology registrar asking for an up-to-date CT for a young patient with Hodgkin's lymphoma on treatment. So this basically seems like probably a follow-up scan in a patient who is on treatment. Obviously, you would want to know more history from the registrar. Is the patient acutely unwell? But basically, this seems like a follow-up scan, which I think can be done and is usually done as an outpatient. Not really urgent, a bit bottom in your list. A colleague asking for CT scan for his mother who is in ED with the symptoms of gastroenteritis. Again, it's a very inappropriate request. Symptoms of gastroenteritis, basically they don't need a CT, even if it's a colleague, your friend. A CT scan is not needed for gastroenteritis. You would just tell them straight away. They can put a scenario like a consultant who is asking for it, because obviously they will just put that in the scenario so that that's hierarchy comes in play. So you would have to argue with the consultant or tell them that it's not required. And if they're not happy, you can tell them that they can speak to your consultant. So again, this is bottom on my list. 80-year-old female with head injury following a fall and on apixaban. So this brings you to the NICE guidelines criteria. So I would advise you to read up the NICE guidance for the CT head. And then you would say, like, for example, obviously you have to know what's the GCS, like if the patient had any vomiting or like fall from height or what, it's a big list. So, but you have to know at least the basic things. So yes, this patient needs a CT scan because they are on apixaban. However, the GCS is 15, there's no focal neurological deficit, headache or vomiting. Yes, they would need a scan according to the NICE criteria. This should be done within 8 hours. So this is second on my list. A medical consultant asking for VQ scan in a pregnant lady with suspected PE is clinically stable. Okay, fine. This patient would need a scan. In pregnant females, they normally do a VQ scan because of the radiation, they're not doing a CTPA. However, you would want to know more information. So you will speak to the consultant. You would say, has the patient had a chest X-ray? Does she have any signs of DVT? Then she would need a Doppler scan. And we don't do the VQ scans over the weekend, and the CTPA still remains the gold standard test. So how would you prioritize these? So as I explained to you, 55-year-old with the tearing chest pain would be the acute aortic syndrome. So this is a spectrum, and it includes intramural hematoma, can have aortic dissection or a penetrating aortic ulcer. So imaging you would do is like you would, first of all, you do a non-contrast CT chest to look for intramural hematoma. Then you would do a CT angiogram aorta. They might not ask you these. These are not radiology ST1 level questions. They sometimes ask in ST3 interviews, but just for information, or if you want to know what type of scan you do, then yeah. Then the second one, as I told you, the head injury would need the non-contrast CT head within 8 hours. The VQ scan in the pregnant patient can be done on the following day. It's not available on the weekend. Ask about the chest X-ray, any symptoms of DVT, CTPA, however, remains gold standard. So basically, you have dealt with 3 inpatients who would need a scan either just now or after a few hours or the next day. And then you would come down to the requests which you think are less important, or if it's an inappropriate request. Like, for example, the Hodgkin's lymphoma patient, it was not urgent scan. The patient obviously definitely needs a staging CT, but that can be done as an outpatient, and PET CT is also done to assess the disease response. And the last one was an inappropriate request and it's not required. So basically you would just reject this request. So as I said, again, reading the scenario, really important. Then you have to know a certain nice guidelines criteria. Familiarize yourself with different symptoms. Again, as I said, go to the radiology department. If you're working on the weekdays, obviously, then you can go even on a weekend. Radiology registrars might be really busy. They might not be able to show you everything, but you will see how the department is working. They're taking the phone calls, they're vetting the scans, they're getting requests for ultrasounds. Even if you learn like 4 or 5 things, it will really be beneficial. And I think it shows in your interview that you have been to the department, you know how things work. Okay. So third set of prioritization that we can get. Any questions, Talia?
Shreve's been answering most of the questions on the chat. So it's
answering the ones in the chat, yeah.
Sorry?
I'm saying I'm answering the questions in the chat individually. So yeah, you carry on.
Okay, cool. Thanks. Oh, sorry. Oh. Okay. So the third set that you can get is like, you may be given a scenario in which you be asked to vet MRI scans. So the basic principle over here is that not to understand exactly what type of MRI is, but also to understand what you will do in certain situations, or MRI is of priority in certain situations, and also to understand like if the patient can't have a CT, or if there is anything which the CT cannot answer, and then you definitely need the MRI. And is this what is it urgent or not? For example, we go through these set. So number 1 is MRI head request in 65-year-old male with vertigo, ataxia, and diplopia, and a CT head is normal. So if someone who has never requested this MRI head, which I normally get every day, 10 scans, the CT head is normal, you wouldn't know what you're looking for, right? For you would assume that a CT head is normal, patient is fine, why do they need an MRI? No, but if they have requested it, obviously they need, but you should know what you're looking for. Number 2, 50-year-old female with lower back pain, saddle anesthesia, bladder dysfunction for last 1 day, orthopedic registrar asking for MRI of the shoulder for query rotator cuff injury, 55-year-old female with sudden onset headache few hours ago, CT head unremarkable, persistent headache, clinicians asking for MRI head, and then MRCP request for 40-year-old patient with abdominal pain. So most of you must have guessed like which one is the most urgent if you have worked in A&E. So the second case, or like the second point in which there's a female with a lower back pain, saddle anesthesia, and bladder dysfunction, you're thinking of chordae equina compression. However, as I said, if you need to know, this is the most urgent request, you would say, I'm thinking of suspected chordae equina syndrome, and I would protocol this as an urgent scan. So it's a non-contrast scan, which we do of the lumbosacral spine. They wouldn't go into details, like, for example, if they can say, for example, if the patient has got a metal in their body, would you still do an MRI? Yes, you can. There are MRI machines or like which are more metal compatible these days. However, this is the most urgent scan, you would say, this would be on top of my list. Okay, so first MRI head in 65-year-old patient, vertigo, ataxia, and diplopia. So they are thinking of posterior circulation stroke. So CT head is normal. Yes, it can be normal because we have ruled out a blade, but we can't rule out an infarct on a CT in the posterior fossa or the brainstem. So that's why this patient needs an MRI. Yes, this is urgent. So let's go through the other option. So probably I would say this might be second on my list. Orthopedic registrar asking for MRI shoulder for rotator cuff pathology. This seems like probably we can do it as an outpatient scan. So you would need to ask for more details if the patient has had maybe like the plain x-rays to look for any bony injury. 55-year-old female with sudden onset headache few hours ago, CT head unremarkable, she has got persistent headache. Okay, so the first thing which comes to your mind, sudden onset headache, thunderclap headache, but they haven't mentioned if there was any loss of consciousness or not. So you're suspecting subarachnoid hemorrhage, right? The CT head is normal. What they should do, the next step is a lumbar puncture. So you have to do a lumbar puncture. So you will ask the clinicians whether the patient has had a lumbar puncture or not. Well, they normally ask for MRI head before the lumbar puncture. In my hospital also, so we have to fight and just say, no, just do a lumbar puncture and see if there's any xanthophromia in the CSF. So again, this would need more discussion with the clinicians. And an MRCP request for a 40-year-old patient with abdominal pain. Again, they have not given you enough history. You would ask what the abdominal pain is, what they are suspecting. If it's an acute cholecystitis, then the first line is an ultrasound. MRCP is something which is done and reported by the specialists, not by the registrars, or probably even by registrars. It has to be verified by the consultant. So it would need discussion with the consultant radiologist. So how would I prioritize these? As I said, first for the quad equina, second for the posterior circulation stroke. Also make sure that the patient is under the stroke team reviewed by neurology. For example, if there's no hemorrhage, have they started antiplatelets, and has the patient been reviewed by neurology, or is there any other differential over here? Third, as I said, for suspected subarachnoid hemorrhage, okay, fine, we'll do the lumbar puncture. We'll do the MRI in this case, but obviously the patient needs a lumbar puncture. If that is also normal, then we can do it just to see if there is any other pathology. MRCP, again, it's not done out of hours, not that I know of where I trained. Ask for more history. Has the patient had any ultrasound and discussion with the GI radiologist? And again, an outpatient scan for an MRI of the shoulder, as we said in the previous case for the CT. So this is how you prioritize, basically starting off from the most urgent and then to something which is least urgent, or if it's not needed. Just remember, they can give you two scenarios which are equally important. And then you would say, I think these are both equally important. And then it's probably more of a discussion, but I think probably they will give you more straightforward cases, but expect anything. Okay, I think I've talked a lot. Yeah.
Can I just stop you there? There are a few questions with regards to this scenario, which I think is best if we tackle them now.
Okay,
The
sure.
first one is, it's saying that the first case could be a potential stroke thrombolysis scan and would need intervention within 4 hours. So would that not take priority over MRI spine, which has a window of 72 hours? I've sort of answered this in the chat. I don't know if you want to take this, Bira, or should I just
Yeah,
explain?
sure.
Yeah, so essentially,
So the question would,
yeah,
so the first one,
this one,
it
yeah.
could be an
They're saying
infarct.
that it could, so they're saying it could be infarct or it could be within thrombolysis window. So why not do MR head? But the scenario
Okay.
already says CT head is normal. Yeah, but I'll let you take it.
Yeah. So I've not put it more complicated, but in our hospital where I work in Oxford, if it's a scan which is within the time window, and if they are thinking the patient could be for thrombectomy, then we would do a CT head and also a CT perfusion scan and a CT angiogram. So all these three things are done. And then the perfusion scan can give you a deficit and can tell you if there was a deficit. Unlikely for the posterior fossa, they don't have really good I don't think they do INR do lots of thrombectomies on the posterior circulation unless it's like a basilar artery thrombus, or if it's in posterior cerebral artery, not like very small tiny vessels like an ICA infarct or PICA, because they're not really approachable. They're very tiny vessels. So for posterior circulation, unless it's mondo, like you'd see the dense vessel on the basilar, we normally don't do. It's MRI. It wouldn't be done acutely. They would go to either under neurology or under stroke, and they would have an MRI the following day.
Can I just
Any
add
other?
something here?
Yeah.
There's one other, but I'll just add something that they do routinely angios even for posterior circulation, because what they want to exclude is a dissection, especially if there is clinical suspicion, because then that's a contraindication for thrombolysis. As far as I know, uh, if there is a dissection, they don't thrombolize those patients, depending on what the clinical scenario
Yeah,
is.
but the CTA would show the dissection unless they're
Yeah,
suspecting there is a perfusion defect, then the INR would proceed with
yeah,
the DSA, that is the subtraction
yeah.
angiography.
Also, stroke is a clinical diagnosis. You don't wait for MRI to confirm
Yeah.
stroke. Um, CT perfusion, MRI. The other question
Any
is,
other
why would
question?
you put, yeah, why would you put SAH third if no further images is indicated at this stage?
As third, I mean, do they want it a bit low down or up? So the main
That's
thing
what they're
is
saying, I
that,
think.
so MRI is quite sensitive even for acute blood. So we do different types of sequences. There is a sequence which is called SWI, that is susceptibility weighted imaging. It is very sensitive for blood. So even if they think if it's a non-traumatic, in this case, it is not, you can't even see the bleed on CT. So the CT head is normal. So the first thing they're thinking is subarachnoid hemorrhage. So they need a lumbar puncture. However, if the lumbar puncture is also still negative, they would ask for an MRI, because it can be some other thing. It could be like a small mass there, which is causing the headache, or to rule out any other pathology, or the MRI can also then pick up small bleeds. Even if it's within one sulcus, it can pick up. So that's how sensitive MRI is.
I don't think we have any other questions.
Okay, good. Okay, I think this is my last slide. So specialty skills, person specifications, really, really important. Umar will go through it in detail because he's the one who applied last year. So I'm quite old and outdated now from this. So you have to know all the domains. You have to know your CV inside out and have to be really well prepared for the interview. Otherwise, what happens? This. So they ask you, and if you are not prepared, you can give some silly answers. So it has happened with people I know who have got really brilliant portfolios, and they have not prepared for the interview, and they did not do well. So I would say preparation is really the key. You have to prepare for the interview. Okay, over to you, Umar.
Hi, thank you. Thank you, Bira. Can I control this?
Um,
Oh, that's all
do you
right.
have it with you?
I
If you can, you'll have to share your screen. I don't know
no,
if
that's
the
all right.
controls.
That's all right. I don't
Okay.
have it in my computer. So yes, that was a very good talk. Uh, uh, I think an interview is one of the most important things this time. I think also last time it was very important. This time it is like 60%, I believe, of your overall scoring. So if you don't do good in interview, you're gonna lose rank. Like by a lot. You will lose a lot of numbers in your rank. Therefore, I think interview holds the utmost value here. Um, I think a lot of people nowadays are quite worried about evidence and self-assessment. And I, as Veera said last year, I did show a fact that somebody who had a very low portfolio score, but uh, but they did really good, like 60 by 60 in interview, and they were ranked in top 20 or something, or top 30 something, which is like which gives you the opportunity to go ahead and train anywhere in the UK. So I think preparing for interview is the most important bit right now for all of you guys who are going to take it. Congratulations on making the cutoff this year. Um, I also, as Bira said, that you have to take a leave on your interview day, and you have to be dressed well. I wore a suit for my interview, um, bought a tie and everything. So, have to invest some money as well. You have to look good, not like how I'm looking right now, but you have to look really good on your interview day. Um, because that's an opportunity to score like 60 out of 60 score, which you won't get. Like self-assessment, I think it's very difficult to score full. MSRA, it's difficult. There's no full score, but MSRA score doesn't matter now as well. But interview is the score, like you can grab the golden points, like all of it, and then you can go first rank, second rank, third rank, whatever. So it does make a lot of difference there. Unless you have like 10 researches and 10 present case presentations and 50 audits, then you can go in your jumpers and you can ace it. But otherwise, look good, dress well. So again, the interviewers will ask questions from the person specification, and you have to go through the person specification at least once to understand what is the essential criteria to get to be a good radiologist, and what is the desirable selection criteria. If you tick box all the essential criteria, there is no way they're going to fail you, because you can fail the interview as well. If you score below a set mark, you probably failed a station, which is not good. You will then fail the entire interview. So you have to score above a set point to pass the interview, and then after that it's all competition. You have to score higher to get a better rank. So if you touch or tick box all the essential criteria when they ask you a question like skills of a radiologist, so you should go through the person specification, and they have mentioned what are the skills of a good radiologist, and then you have to tell them how you relate to that, and you tick a box, and then you will pass the interview. To to score even higher, you need to meet the desirable criteria as well. So anyone who has worked harder for their portfolio will have the desirable selection criteria, and they will score higher. So it is like that. They won't ask you just a random question out of nowhere that what is this. So there is a course. There is a course for interview. There is like a they have given you like a course that you can go through, and you can find out what you need to know to answer questions in interview. So it's good that you go through Oriel and read the person specification. I think we have it on this presentation as well. We'll go through that. And then there's one thing that's the specialty specific essential criteria. I think that is the thing that needs to be focused most on, because all of the questions will be specialty related questions. Like, for instance, there is clinical governance, but then they will ask you what is radiology clinical governance. Um, what are the new technological advances in radiology? What do you know about radiology department? These are the main themes of question, and all are related to radiology. And you have to get yourself prepared to answer the question. You cannot think about what to answer at that point in time. When I was doing this mock interview with one of my colleagues, and they asked me, okay, so why do you want to choose radiology? And my answer was, oh, I have done this and I applied for radiology, I took this much marks and blah blah, and all of it didn't make any sense. Then I got to know that they ask you a question, and then you have to relate back to the person specification and tell them answer from that, like, okay, so why radiology? Do I stand on the person specification? What I have done uh, to what I have done that is related to radiology, and then you tell them from that person specification your answer. You just don't answer them randomly. um, that's one point. I think it's best that you read those specialty specific essential criteria. So I think this is person specification essential criteria. This is like clinical knowledge, interest in understanding of the training program, and you get this from your taster week. Even if you don't get it, but you need to know what is your understanding of this training program. Um, how long the program is, how the department works, uh, how do consultants work, what is the life of a radiology registrar. All of these things you have to tell them in this um, area. Now, there are workplace skills like ability to work in a multi-professional team, and now they will ask you a question that are your team can you work efficiently with your team? So this is a question. This is the interview question. Um, to answer this question again, you have to first go back to radiology and tell them that radiologists work in team. They attend multidisciplinary team meetings, stuff like that, and then you have to tell them how you have worked in a team and give an example, like a personalized example of how you have worked in a team. But first, you have to go back to radiology, tell them that they work in teams, they do MDTs, something like that, and then you carry on by giving a personal example, and then you end the question. So this is in the person specification, that ability to work in multi-professional teams. So that means they can ask you this question: that are you a team player? Do you work efficiently with a team? Then there is ability to lead, make decisions, organize, motivate. Again, I think in the self-assessment, in the portfolio, you have a domain in which you have leadership qualities. So this goes again to that. You say radiologists are leaders, consultant do supervision for the trainees, for geographers, they lead MDTs. I myself was a junior representative in some committee or this and that, and I've done this for that committee, showing positive results, and end your answer. So again, this is in the person specification. So we know that this question can come up about leadership, uh, and then we need to know how to answer this question. We go back to radiology. We start by talking about radiology and leadership involved in radiology, and then we go to a personal example, and then we end the answer. So you have to personalize the example. You have to tell them from your portfolio. You have to tell them what specific leadership position you had, what was your role in that, how did you motivate your team members in that, and what difference you made while being that in that position. So again, you have to answer this question in points like this. You cannot just answer randomly, I was just a junior representative in this committee and that's it. If you say that, it's okay, but you have not correlated it with radiology, which you have to do. An ability to manage, prioritize, own, and other time effectively. I think this comes in clinical prioritization, which you already gone through. Uh, Ability to monitor developing situations and anticipate issues. Again, this is the clinical prioritization skills, which I think is which takes a full whole station in the interview. So in our time, it
I,
was sorry.
yeah, so this is basically I've just put in, and then I've also put in the questions. So if you want to go through them, and then
Yeah,
one by one. So
yeah.
this is this. So
Okay,
from the
yeah,
essential criteria, then these are the domains that you need to cover.
yeah.
So yeah.
Yeah, so importance of teamwork. You have to give an example where you worked in a team. But first, again, you have to tell them that radiology or radiologists work in a team. They work with radiographers. They work with other specialties in MDTs. So this is a very important quality of a radiologist, to be able to work in a team. I myself had did this, give a personalized example where you showed an example of teamwork and had a positive outcome. This is how you have to answer uh, the question, because it's basically a tick box. They will listen to you that you know about radiology, you know how how radiologists work in team, and then you have given a personalized example. So your answer should be very well structured so that they understand what you're saying and they can tick those boxes and they can give you a full score. I've spoken about leadership skill again. You have to tell them that a good radiologist had good leadership skills because they have to supervise trainees, they have to supervise radiographers, they have to lead MDTs. As therefore, it is very important for a good radiologist to have good leadership skills. Stop. And then you give your personalized example. Like I was, uh, I myself was a stroke radiology liaison manager. I used to run weekly stroke radiology meetings. I used to take down interesting cases to take to that meeting. Then I used to gather the outcomes and correspond with the patients and tell them what the outcome was of their case in that meeting. And then I used to do audits as that in that managerial post. So that was my answer. That uh, that first I said radiology people have good leadership skills, and why? Because they have to do this, they have to do this. Then I told them I myself was a manager, in which capacity I did this, did audits, did arranged meetings, weekly meetings, attended like 100 meetings, spoke with the patients about the outcomes of their cases, because sometimes stroke physicians don't know the answers to all questions, and then they take those questions to a neuroradiologist, and then they both sit together and devise a management plan, and then I correspond that management plan to the patients. So it was a detailed answer. They knew that I've done this post now, and they also know that what was my role in that capacity, what was I doing, uh, which will give you a full score, because I've told them that you know what radiology people do and how you have done it. So a personalized example is very important. Working under pressure and knowing your limitations. I used to answer this question like uh, always, like, because once you start practicing same thing again and again, it just comes to you naturally. I would say that the on-call radiology registrar is a very busy person, and he takes like 100 calls a day, works under pressure, um, uh, trying to prioritize cases and trying to discuss with acute clinical teams. And then I would tell them that I was a stroke registrar who had to deal with um, acute stroke patients, uh, to make sure that they get their treatment within time. Brain is time. So one of my feedback, they especially highlighted brain is time, that I used to work under pressure, and they liked it that I said brain is time. I used to go and see acute stroke patients, communicated with radiology team to get their scans vetted as soon as possible and get them to IR if they need thrombectomy or not, and stuff like that. So that was my example of working under pressure. If you're FI2, you work in acute in A&E, you need to come up with a personalized example after telling them that radiology department is a very busy department, and they work under pressure, and you have the skills, and why, by giving the example, and that skill makes you a perfect fit for a busy radiology department. So it's like a full circle. You come and tell them that yes, radiology department is busy. I have this experience of working under pressure by giving this example, and this is why I am a perfect fit for a busy radiology department. And they'll say, wow, very nice, okay, you can come. uh, a mistake you made, I have never come across this question, but I think a mistake you made, you have to be very honest about that mistake that you made. Again, don't answer this question straight ahead that I was in A&E and I did not prescribe aspirin for a patient or did not prescribe this for a patient. Tell them that I know from my taster week that radiologists also make a mistake. Uh, Sometimes they miss significant things in a scan, um, which then go to radiology events and learning meetings. So they know that you know about that as well. That radiologists can make mistakes, and how do they rectify it, and how in a friendly environment they discuss to overcome this problem that it doesn't happen again. And then you can tell them about your mistake that you made, and how you rectified it, and how you made sure that it shouldn't happen again, not just to you but to anyone else who can make the mistake as well. A mistake that you make, somebody else can make as well. So if you just tell them that I made this mistake and I'm sorry, won't do that again, you won't score. You tell them that first of all, I know that it always makes mistakes as well, and how do they rectify it, and what uh, like what things they have in their system, like real M meetings, or like departmental meetings. Like real meetings are like radiology events and learning meetings. They need to happen at least 6 times in a trust. So these meetings are where they discuss cases where some things have been missed, which was significant, and then they discuss how to make sure that these things don't get missed. Like recently, we had a meeting where they said we should come up with a pre-form performa for rectal cancer reporting. So if you have a pre-form performa for rectal cancer reporting, you would have one, have you looked at this? Two, have you looked at this in the scan? Three, have you looked at this at the scan? Four, have you looked at this in the scan? And then all the radiologists will look at those things in the scan by reading that performer, and there is a very less chance now that they will miss it. So this is how they have overcome this problem. Similarly, you would say that they can make mistake, how they rectify it, and then you give your personalized example that I made this mistake and then I did this, how I rectified it by speaking to my consultant, speaking to the patient, made sure that they were aware that I have made a mistake. I duty of candor or whatever, and then how I made sure that this doesn't happen again. So this is like a whole, you again come full circle, full detailed answer, and probably full marks. Now,
So I would, sorry to interrupt. Yeah, so
yeah,
I mean, it varies how you approach the question, but
yeah,
I think for me, I would be like, if they ask me a mistake I've made, I would start off with my own example. I would
yeah,
probably just start off by saying, mistakes can happen in medicine, and there are, because obviously we are all working in a very busy environment, and please don't mention a never event. That's what I would say.
yeah,
But then it should be a mistake which you have done, and then what you learned from it and how you reflected on it, that's the main important thing. And then you can relate back to radiology, because you might not have enough time if they're,
yeah,
because then they can ask you a follow-up question, for example, so do you know how mistakes are dealt with in radiology? And then you can go on to mention the RAL meetings. That's how I
mm,
would approach the question.
yeah,
But then again, it's up to you. Again, as Umar is saying, one personalized example, this we have just put in just to make you aware that you should have an example of every question or scenario or one domain. You should have an example of team working, one leadership skills, managing under pressure. Then can you tell me an example or a scenario where you worked under pressure? Then what happened? So again, understanding that STAR approach, like what was the situation, what was the task, what was the action, and how you reflected on it. So these are the main things. And then in the end, we'll also tell you resources which from where you can read this up. Yeah.
yeah. I think that's fine. Absolutely fine. As long as you rate it to radiology, because that's what they're looking for. Even in the beginning or in the end, it's totally up to you. Um, uh, if you think that you have more explanations to do, so you can start with your example and then relate it to radiology, so that they know that you know about how mistakes are dealt in within the department of radiology. Sometimes consultant won't prompt you, sometimes they will. Okay, tell me about how you how mistakes are dealt with in radiology. So then you would answer that question. Sometimes they won't, and then there's a chance you might lose a mark because you did not relate it to radiology. So of course, start with your example, but end it with radiology, or start with radiology, end with your example. One way or the other, make sure that you make a connection, because this is a radiology interview, so you have to make that connection. Even if you don't make the connection, then you have to be prepared for a follow-up question like how mistakes are dealt within the radiology department, and then you have to know about those meetings, just one meeting, real meeting, which is very important. I think you should just you need to know the abbreviation of it, and what happens in that meeting. That's it. Not a lot of details, but you should know, because they will definitely ask you how mistakes are dealt in radiology. They will ask you to connect it to radiology. Now, they can ask you about researches. Should all radiologists do research? And the answer is always yes. Again, they are not asking about radiologist research. I'm be very honest with you. They're not asking about you to tell them how radiologists have done research in the past. They're asking you about your research. They're just asking you uh, in a way that should all radiologists do research or not. You would say yes, and then you would tell them why they should do research, what is the importance of research, and what research you have done. If you haven't done the research, then this question is not a good question for you. But there are ways to tackle that as well. You can talk about research that you were doing, or you're planning to start, or what you have in mind. So the main theme of this question and the answer to this question would be that you know that research is important in radiology and why it is done in radiology, and you know what is the basic concept of research and what are the key steps in research, and how research changes medicine. even if you have not done a research. So if you answer this question like this, you will surely get a good score, because so if somebody asked me out of nowhere, have you done a research, and I would be like, I'll be blank. Oh, I haven't done a research. But I can answer the question by telling them how important is research for medicine, what are the key steps of research, and what I have in mind for a research project, or what I have started a research project or something. You don't have to tell about a completed research. It's the interview. You can tell them that you have started a project or you're planning to start a project, and you know the key aspects of research, and you know how research helps in medicine and how it changes the practice or stuff like. What is the definition of research? That as well. So when they ask you, should all radiologists do research, the answer is yes, and then and then you need to tell them what is your understanding of research and what is your understanding of research related to radiology. um, Teaching experience again. I think most of you guys have teaching experience because it's the main bit of the self-assessment. So either start with radiology or end with radiology. That radiologists are good teachers. They teach. Uh, they supervise. They teach their trainees. They teach the radiographers. Put it in the end or put it in the start. But then give your example of your teaching. I have done international or national or local teachings, this many teachings on this topic, and I have excellent feedback from my students or medical students or my colleagues. If you have won a prize, tell them about the prize. If you have done international teaching, tell them about it. Tell them about the feedback as well, which you got. These are very easy questions and very easy to score on, because if you have teaching, you just need to tell them what you have done. So it's not like something you have to go and learn about. You just need to tell them what you have done, how you did it, and at what level you did it, and why, and how being a good teacher will help you in radiology as a registrar and then as a consultant in the future. So it will help me in the future, because I know. So first you tell them about your teaching, what was your teaching, and at what level it was, and what was the feedback, and then you tell them this will help me in the future as a radiology registrar, because we have to do teaching observations in radiology. That's a key aspect of portfolio, at least two a year. So my teaching skills will help me quite a lot in my during my radiology training. And once I'm a consultant, it will help me further because I have to teach the radiology registrars and radiographers. So teaching is a very important skill of a good radiologist. You end your question like that. Knowing about ST1 portfolio is very important, because if they ask you a question like, what do you know about like a day of radiology registrar or how radiology registrar work, you have to tell them about their portfolio. What are the key
Yeah.
portfolio?
So sorry, Umar, to interrupt. I think that we are covering this in the next, because just in the interest of time, I
Okay.
think we are
Yeah,
quite a
of course. Oh, sorry.
yeah.
Sorry. Yeah,
So
yeah. Okay.
yeah, because if you can
Uh,
just keep it
of
brief.
course. Yeah.
So
Yeah. Just got lost. Okay. Evidence of experience in range of acute specialties with experiencing of managing. Okay, so this is, I think, clinical prioritization, isn't it? Specialty specific essential
yeah.
selection criteria, which we have already covered about everything. I would just say that the main theme is that they will give you prioritization scenarios, and you have to prioritize the scan, and you need to make sure that you know why the scan is important, as Abida have said, and you also need to know if there's any alternative to that scan. And I think most of the colleagues which I spoke to, most of them had this prioritization skill, where they ask them to vet the scans and tell them why they have prioritized this one over this one. Then commitment to specialty and understanding of the use of modern imaging technique in current clinical practice. You would think that this question won't come, but this question came for a lot of people. To be very honest with you, that what do you know about scientific and technical advances in radiology? Difficult question to answer. I was not prepared for that one, but you you need to know what are the new scientific or technological developments in radiology. One is AI. Then we have interventions. A lot of new interventions coming up. We have proton beam therapy and PET CTs and PET MRIs. I don't know if you guys would know about that or not, but at least know about two like AI and interventional radiology. And then you have to start with your taster week again. In taster week, I saw AI, how AI helped, and what AI was on. In my field, it was on stroke, looking at CT scans. If you have come across AI, tell them about that, give example of the AI that is being used in your trust, and then speak about intervention radiology, how they did procedures like uh, whatever procedures you saw, and that's advancement in radiology. So this question can come. I would probably answer this question in the group as well in detail about how to answer this question. Then again, evidence of time spent in nuclear medicine, radiology department, observing the work of radiologist. So this is again coming from your taster week. You have to tell them what you how your taster week was and what were the main learnings from your taster week in tick boxes like ionizing radiation, like how interventional people work, what is nuclear medicine, again what is how nuclear medicine works, uh, a lot of radiation in that as well. So you have to give some key points of all of these to make sure for them to know that you know what are the key points through your taster week. Just don't tell them about you went to this academy, you went to this. You need to tell them that what you actually learned from that taster week, like interactions with radiology, and you worked with the consultants, attended multiple MDTs. You need to tell them what MDTs you did attend. You need to know about academy and a conventional style of radiology training, which is different. So you would need to get some understanding of how academy is different from conventional training. Again, on-call workload and pressures, how busy a on-call radiologist is, and how he communicates with clinical teams and cope with pressure. Team working and IR, interventional radiology. Again, this you can use this one for the advancements in technology as well. When you talk about IR, don't forget to talk about ionizing radiations and lead aprons and thyroid shields and dosimeters. It's okay if you don't guys don't know about it. I'll probably I think I've already answered this in the group, but I'll put more answers in the group as well, hopefully. uh, Skills and qualities of a good radiologist, and this is basically your portfolio, your teaching, your leadership, your uh, research, your case presentations, and your teaching qualifications. If you have all of these, you need to say all of these in that. Just tell them a good radiologist is a good educator, teaches registrars, radiographers. I have a PG cert, or I have done this international teaching. A good radiologist is a good leader, and I have this leadership quality, and I have done this. I have maintained this leadership role during my training or during my work as a as FI2 or as an ST1 doctor. So again, you have to tell them about your portfolio here and relate it to radiology. This is the way to answer this question. So you need to know your portfolio inside out. You need to make sure that you remember everything that you have done, not just self-assessment, even out of that. So this is the time you can use any thing that you have done previously, even if it falls in your self-assessment or not. You can use it and you can score on it. They don't have that in front of them, and they won't check it. But if you have done something that did not give you a score in your self-assessment, will definitely give you a score in the interview, if it correlates with radiology and stuff. Skill mix is it's like I think a buzzword. It's basically used in radiology, where I think the radiographers are reporting X-rays, and so I think some are reporting CTs as well. So these kinds of words like skill mix, teleradiology, turf wars, these are I think in a green book for radiology interviews. You need to know what they mean, and uh, and you would need to explain this as well if they ask you about skill mix or teleradiology or turf wars, and they can ask you this in different style of questions, like what problems is the radiology department facing nowadays. And when you one way of answering, like one point in this one answer in this question would be like a lot of reports, and how do they deal with, they have something called teleradiology and outsourcing. And teleradiology is basically a different trust or a different private radiologist reporting scans for us for our trust, and so they outsource it to different private companies or different trust, and then they report their scans. So these are like some buzzwords which you would need to learn and explain to them what they are. And there is an interview book which does cover all of these buzzwords as well. um, I think we had
I
already
think
spoken about
we have
modern
already
imaging
covered.
techniques. Yeah, AI. And
Yeah,
so modern
as
imaging
it
techniques, I will write an answer for this question, the advances and scientific and technical advances in radiology. I'll definitely put an answer for that, which will give you an idea about what to say in your interview, because it's a difficult question which did come up last time. I will put an answer hopefully, and then you guys wouldn't have idea what to say.
Okay. Thank you, Umar.
No problem. Thank you.
So I'll just cover the last bit just for the AI and the workforce census. So we will also share this in the chat box. So as Umar was telling you, we have the RAL meetings in the department, and these is the newsletter which all the members of the Royal College they receive. So this is it's a document which has got a few cases and how to reflect on it. I think this one is another important document you should read. This is Clinical Radiology Workforce Census. The last one I remember that was in 2023. I'm not exactly sure if the new one has come up, but it's worth reading. This is available free online. You can just Google it. And if you want, we can also put it in the chat box for the PDF. So it shows you the workforce crisis, how many radiologists are on a shortage in the UK and how many radiologists are needed. And then obviously there's a backlog of lots of reporting that needs to be done. So I think just worth reading a little bit of at least the major points, the graphs, which you can probably just say it in your answers. You just have to incorporate those because you don't know what they're going to ask you. Okay. So just to end, what's the take-home message? I think the most important thing that Omar was saying with the person specification was person specification is a document from which you have to prepare for your interview. I remember when I was looking to applying into radiology 7-8 years ago, and I asked, it was my first job in the NHS, and I asked my colleague who was a medic, and I asked him, I'm interested in radiology. And he told me, just read the person specification. And I thought he was not really helpful. But probably I thought because he was a core medical trainee. But to be honest, yes, when I got into the cycle and I was preparing for the interview, I just printed it off. And then for every domain, you just circle it. And then, as he said, okay, fine, I've covered this prioritization skills, this leadership skills, and all the questions that can be asked in that domain, you have to prepare the answers for that. So preparation is the key. Start now. You still have got 3 weeks. Practice, 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 which is really important. For some people, it comes very naturally. They're really good at interviews. For others, they have to prepare a lot. For some people, English is not the first language, also for myself. So I have to practice. So I have to write down the bullet points. Like if they're going to ask me this question, I'm going to cover these 3 domains and I'm going to speak on that. And then I'm not just going to write the bullet points, I'm going to practice it. So you can practice with your colleagues, you can practice with your friends. And ideally, once you are little bit prepared, you can even ask one of your seniors, like someone you find intimidating, a consultant colleague, or like a radiology. If you know people in radiology, radiology registrars are really helpful. You can sign up for mocks anywhere. Lots of societies that do mock interviews. So I think practice with the people you're not familiar with, so that you just feel a little bit of more pressure and who don't know your CV inside out. You can even practice sitting in front of the mirror. When I was applying 6 years ago, there were not many courses. There was a course I went to, there were like 300 people in that course. When I went for the interview, they asked for my like physical portfolio and they said, just tell me about yourself. And then I just started talking about it. And then after like 3-4 minutes, they said, yeah, you're good to go. You'll get the job. And I was like, I didn't get any feedback. So but nowadays you have got lots of people, you have got lots of opportunities. So practice with a lot of people. Your environment while during the interview, make sure that your internet connection is good. As I said, you should not be at work. Your issue should be on your laptop or your whatever the windows, but not on your phones. Make sure that there is a good light, the speaker, the mic, everything is working. Don't leave them for the last minute. Yeah, fine, my laptop works fine. No, something bad can happen. Always have a backup. So these are like things which are preparing you for the interview, but the time goes really fast. That's why I'm just putting these points there so that you are prepared in advance. So this is how you should look like. I think you should be alert, you should be well rested. And as we said, Umar was saying, you should put your suit on or maybe a tie, or well alert and listening to the questions carefully. And you can even ask them like, I think some people, they one off, something happens, and some people, they have some technical issues. So they always make a note of that. And you can always respond back to them. And I think they make a note of it if there's an interruption during your interview or there's a connectivity issue. So don't worry about that. So I think that brings me to the end, and that's it. That was my
Sorry, can
slide.
you go back to your slide in the book section, because the book that I was talking
Oh,
about
did we
is
miss
in
it?
it. Yes, I think a lot of questions
Oh
about that.
yeah, I think we missed it. Oh
Yeah.
yeah, I don't know.
So
Oh
the
yeah, we
green
missed
book,
it.
yeah.
Oh
Uh,
sorry, I don't know how we missed it. I think
the green book
just
have a
came.
lot of radiology related things, all the buzzwords as well. I would not recommend cramming these books. Just going through them, like don't even go through once. Just make sure that you go through the highlighted stuff, because you need to personalize your answers. And as Abira said, practice with colleagues. You would practice the same question and the same answer every time. It will get boring, and you will think I'm repeating same thing again and again. But remember that on the interview day, it would be like the first time you're answering that question. So make sure that you practice a lot with your colleagues. And these are the books that I was talking about. And this green book has the radiology stuff. And this was recommended to me by Abira last year.
Yeah, it has. I think I have not read this, but I think one of my trainees have read this book, and this is the basic book. I think everyone prepares. So this is like, it gives you a general layout of like how to approach ethical questions. The camp structure for like tell us about yourself, which I think previously in the last year they didn't ask, but I think you should have like a structure to your answer, even for like examples. I've interviewed people like for mocks, and then I ask them an example, and they just keep telling me the story on, and they don't realize that the time is going by. It's 10 minutes, it's really quick. You have to be quite engaging. Your message should come across, the answer should be crisp, it should be practiced, but not too well rehearsed, if that makes sense, right? So, yeah, so always have an example ready in your mind, and then just practice it, that how would you describe it, or how would you say it. So you have to practice that out loud, otherwise you won't know what to say. Okay. Do we have any questions, Shoaib and Dalia?
No, I think most of them have been covered. I haven't come across any new question, unless there is any new burning question that the audience has. Khalid Aga has raised his hand. Khalid, please feel free to unmute yourself.
Hi, thank you, Abira and Omar, for the talk. It was very helpful and very informative. So my question is about the possible question. If they ask us to talk about why we want to train in radiology, in this case, do we need to link anything to our portfolio or to the self-assessment, or is it purely just talking about why we want to specialize in it?
Yeah, I think I did put a sample answer for the same question in the UKRST group, and this question is basically about your portfolio, nothing else. Why you want to train in radiology, why radiology, and then you have to tell them that uh, tell them the good quality of a good radiologist and how you stand on those qualities, and that is why you want to you want to get into radiology field, because you think you have the qualities of a good radiologist, which will help you become a good radiologist. So this is like a paraphrased question asking about your portfolio, which seems like some people say, "Oh, my father was a radiologist, that's why I want to become a radiologist," or something like that. But it's not that. You have to go back to your portfolio. Tell them that leadership is a quality of a good radiologist. I was a leader in this. Uh, knowledge is a good quality. I have membership exam. I have research. Um, Audit is a good quality. I have these many audits under my belt, and all of these qualities, I believe, would help me become a good radiologist. That's why I want to be a radiologist. It's all tick boxes.
Yeah, I would approach it like as I said, everyone has a different way. So people have like they follow a camp structure. Like for example, I think clinically that's probably a bit of an old way, or like okay, I think clinically I've done this, academically I've done this. So if the interviewers are listening to the same thing from morning, they might get bored. What you can also do is that some people have a lot of things in their portfolio, right? They might have like a 40 score in their portfolio. So, and some people, they might not have a lot of things. They might have more like communication skills. So I would say you can say, oh, there are a lot of reasons why I want to do radiology, but I think the top 3 reasons or top 4 reasons why I want to do radiology is I think radiologists are really good communicators, or like they have great communication skills. And then you give your own personal example. And personally, I demonstrate this, and then you have to give them an example that how you demonstrate it so that they are convinced, right? And then you say, I think I have excellent leadership skills, which I think is an essential part of radiology. As Umar had said, then you link the MDTs and your previous experience, and I have excellent team working skills because I've seen in my taste a week how the radiologists, they have to the supervise the trainees, they work with the radiographers, sonographers, so all these skills. So these are the reasons. If you are doing it on the camp structure, then you can link, if you have done any exams, then you can link your exams with that. Like, I know that radiology has very the exams are very hard, and I think I have a really good clinical and knowledge and skills, and I've done my MRCP or postgrad exams or whatever exams you have done. So it's variable according to different person. Write down your answers, 2 different sort of sets. You can write your bullet points and then just practice how you want to do it. And the main thing is then practice with someone who can give you some feedback. Okay. Any other question?
Okay, thank you.
I don't
We
see any other
have
hands, so I
shared the
think
feedback form. Before I forget, yeah, just please make sure to fill in the feedback form. It's really helpful for us to organize further webinars. Any other burning questions you have? So we will be doing the mock interviews this year, as we have been running for the last couple of years. Hopefully you will be notified at least 48 hours in advance. So we aim to start this week. If you haven't started practicing, just start practicing from today or from tomorrow. And then it would be on the first come, first serve basis, because sometimes we have a lot of interest, but we are really short of time. And the trainees who are doing the panelists or the trainees who are doing the mock interviews, we have limited capacity. But we'll let you know in advance, but they will start this week. And just make sure that you're up to date in the group messages and read them. Okay. I think we'll wrap up then.
yes, I agree. I don't see any other questions. Yeah, I think we'll finish here. Thank you everyone for attending, and please do fill in the feedback form as Abira has mentioned. And I'll leave it to you, Abira, if you have any final
Okay, yeah.
comments.
Can I just say
Others,
something? Sorry.
yeah,
There was
sure.
a question about somebody did some management role, but it was like something they did, but it didn't happen before their end of submission for portfolio. Can they include that in interview? Yes, 100%. You can include anything in the interview which will get you points. They would not assess at that point in time if you did it before the deadline or after the deadline. If you have done it, tell them and you'll get a score.
Okay, good. Okay, thank you everyone. Thanks for joining, and best of luck for your interview.